Good afternoon, everybody. Firstly, welcome to everyone joining the session this afternoon. I hope you're not too virtually fatigued. I'm Cathy Lilley, Director of Corporate Governance at East London Foundation Trust, and I'm absolutely delighted to have been asked to chair this session, which focuses on two member showcase submissions on a very topical and current matter around joint posts and committees in common. Many of our trusts are working increasingly together, and these two case studies describe sort of different integrated structures designed to improve oversight and accountability and ultimately deliver better care for our residents. So the format for the session this afternoon is that for each case study, you'll firstly be shown an animation, and this will be followed by a presentation. Once both presentations have taken place, there'll be a question and answer session. So please don't forget to think about the questions you'd like to ask and to post them in the box on your screen. The first case study is on establishing the Leicestershire Partnership and Northamptonshire Healthcare Group. And I'm delighted that Fiona Barr, Director of Corporate Governance at Northamptonshire Healthcare FT, and Kate Dyer, Deputy Director of Governance and Risk at Leicestershire Partnership Trust, will be presenting afterwards. So without further ado, over to the animation, please.
As organisations across the NHS in England are being encouraged to work more collaboratively together ahead of the changes to legislation that will formalise integrated care systems, Leicestershire Partnership NHS Trust and Northamptonshire Healthcare NHS Foundation Trust created a buddy system in 2019, following the appointment of a joint CEO for both trusts. The trusts developed a strong relationship and in April 2021, with the support of NHS England and NHS Improvement, progressed their relationship further into a formal group model. The Leicestershire Partnership and Northamptonshire Healthcare Group is based on a Memorandum of Understanding. They established two identical committees, one in each trust, that came together as a joint working group to oversee the delivery of a programme with joint priorities as agreed by both boards. The arrangement gave rise to several shared directors and had a significant benefit for the trust stakeholders. There is now greater representation of local communities, and working together has enabled the trusts to strengthen their respective position, scope, reach and influence within each ICS, the East Midlands and beyond.
Good afternoon, everybody. Both Fiona and myself are really pleased to be here today, and we'll be taking alternate slides so that you get to hear from both of us. So we're here to describe the development of a group model between both of our trusts. Just to set a bit of context, this started out with a buddy arrangement because LPT is CQC rated requires improvement, and Northamptonshire Healthcare Trust is rated outstanding. So that buddy arrangement was in place. We have a joint chief executive for a few years now, although we both remain as separate sovereign organisations, retaining individual organisational identity and accountability. So both trusts have similar portfolios. We both deliver mental health and community health services, but of course we're not identical. LPT is just slightly bigger, and there are some key differences, not just in the CQC rating. But obviously NHFT is an FT and LPT isn't. And we have different geographical and ICS areas. So I'm going to hand over now to Fiona to talk through the agenda for this session. And next slide, please.
Thanks very much, Kate, and good afternoon, everybody. So I'm going to give you a little bit of a flavour of what our group model is about. In fact, our presentation is going to give a flavour. So we've been in operation for just over a year now, and our group model is really grounded in improvement, in identifying improvement projects and identifying improvement areas for both organisations. So what we're going to do in our session is really give you an overview of what we've done, how it's going, where some of the challenges have been, and how we've been tackling them. What we're trying to do, given today's audience, is really try to focus on some of the governance dynamics, and of course, very happy to answer questions at the end. So Before we finish at the end, we will give you a glimpse of what's coming up next, what factors are actually starting to influence this. But I'll now hand back over to Kate to start to take us through a little bit of the opening detail to really set the scene for what we've been doing.
Thanks, Fiona. Next slide, please. Okay, so as you would expect, we've had some challenges along the way. None of them have been insurmountable, and they haven't really impacted on the development of the group model. But I've just listed a few there for you. I'm just going to take the top one because really that was, I guess, the biggest challenge for us in starting this group model, and that was around mainstreaming complex governance. And by that, I mean being able to explain the different options to all of our different stakeholders who may or may not be that well versed in different types of governance. So the arrangements for the collaboration were set out in the Memorandum of Understanding to establish a group model. And we needed to discuss options for operationalising that group model. They needed to be understood by all of the members of both of our boards so that they could make an informed decision together about how best to take this forward. We're also conscious from a well-led perspective that both sets of board members needed to understand and be able to describe the structure and the purpose of the group really clearly. So we needed to find a way to support two boards to work together in a streamlined way. So we did this by setting up a committees in common structure with the terms of reference for each trust, detailing the arrangements such as having an equivalent membership in each trust. And that includes the chair, the chief executive, and some of our executive and non-executive directors. So of course we needed a space in which the committees in common could work together, and we do this via a joint working group. The working group draws its membership from the committees in common, and it's chaired by each of the trust's chairs on an alternate basis. And the working group is accountable to each board through the trust's respective committee in common. It meets regularly to oversee a set of joint priorities and to monitor progress against those work streams and have oversight of any risk associated with the delivery of those. So ultimately, both boards retain control over they approve any of the changes made by the joint working group because that group is a non-decision making forum. So the structure is in place, and
I think we've got an issue with Kate's connectivity, please. Thank you.
Yeah, absolutely. So we just got up to talking about how we set up these two committees in common with this space of the joint working group. And the joint working group is really where the two committees in common come together with this equivalent membership. There is clear and equal representation from both organisations to enable them to make these decisions and identify these priorities together. And the JWG is chaired by each foundation trust, NHFT and LPT chair on a rotational basis. The chief executive is one of the key joining factors between both trusts and obviously the operation of the JWG. So the JWG is really the engine room of where we are actually building our priorities and making sure that we're very clear on the progress against those priorities. What I must make very clear though is the board ultimately has control over what those priorities are in our joint programme and receives regular reports on progress. We're just about to start a new planning round to actually look at what we might do for next year, because we're coming to the end of the first year of operation. And because this structure is now working well, it's established in both organisations, we're looking to actually build on we're looking to build on that and step even further forwards in our group model arrangement. So if we move on to the next slide, and we can just talk about kind of what's going well. So I think it is really important. I know I don't want to labour this point, but this really is a group model that's based on improvement objectives. So we're in different systems. We operate in a very similar way, and we've got a very similar services. But what we really wanting to, we've got two separate strategies, two sets of strategic objectives. And what our group model arrangement is really helping us to do is really try to build on areas which will enhance our overall performance, and that will enhance the delivery of our strategic objectives, but don't really, it's not necessarily in support of our specific strategic objective areas. What the group model has really enabled us to do is galvanise support, really focus attention, marshal our resources on some key areas, and Kate will in a few moments will take you through the different priority programme areas that we've identified. It's a good opportunity to actually problem solve together, to identify ideas for where we can work together and then solve those problems together. And we have two senior leaders, one from each organisation, that takes ownership of each of the joint programme areas. So we have an ambition for each programme area, and then we have a set of deliverables, and all of those are reported to our boards on a regular basis. It also provides us with a bit of an opportunity for mutual aid and support, and really kind of finding our pipeline of ideas of new improvement projects from our staff themselves. That is gaining a lot of traction in both of our organisations. People are really starting to see the benefit of working together, but it's a very natural way of working together, where we're really being led by some of the ideas that colleagues are coming up with themselves. It's also given us an opportunity to make some more structural changes to actually work better together as two organisations. So, for example, we've aligned our board arrangements so that we can actually streamline our reporting and our governance structures. We've looked at how we can, things like our risk registers, for example, we've got a number of joint and shared directors, we've got a joint chief exec. We're looking at actually how are we articulating risk between both organisations. Is that similar? How can we actually help? How can we help both organisations to report risk in a particular way? And what's our decision making like? As Kate mentioned earlier, we're an FT, LPT is a trust, so there are some differences in arrangements. But where we can, we've tried to get some sort of commonality of structures, start to harmonise some of the work that we're doing. So I'm going to hand over now to Kate for the next slide, because I think you might be interested in actually seeing what some of our priorities actually are. So back over to you, Kate.
Thanks, Fiona. So yes, so you'll see on the slide in front of you, these are the priorities that we've agreed for year one, and I won't go through all of them, but just to say really that each of these areas support the improvement and learning that underpin pretty much any trust, and will probably be common to your organisation too. And they sit alongside our individual sets of strategic objectives. So we held a joint board session to agree these priorities, and agree that these all sort of build on areas of our common purpose. You'll see there that there is a joint governance one at the top in the middle. And you might think that actually joining an FT and a non-FT in a sort of strategic governance ambition might be quite difficult. But there hasn't been. We obviously LPT doesn't have governors, and there are some differences in the way that we govern ourselves, but we have a lot of areas of common purpose. And we have a strategic ambition to deliver best practice governance, to contribute to system governance, and to be enablers for agile and effective decision making. So those are the key areas that we're really focusing on in year one. So lots of activity going on in each of these areas. And I'm going to go back over to Fiona now just to talk about another element of the programme. Thanks. Next slide, please.
Thanks, Kate. Sorry, my mute button wasn't performing then for me. So what we just thought we'd just pause on here for a moment is a joint role that we've identified in research across both organisations. I mean, for both organisations, I mean, for all organisations up and down the country, actually developing that pipeline of your medical staff is really important. And what does attract people? Well, it's research opportunities. And by having a joint role looking at research across both organisations, it just enables us to actually get a few more bangs for our buck, you know, really collaborate on areas where we can do some joint research projects together. That will enable us to actually attract larger research budgets. That in turn actually makes both organisations a very attractive place to come. And we're all looking for staff to fill the roles that we've got, the roles that we will have in the future, and actually using research as an opportunity to really shine a light on both of our organisations through this groundwork really of improvement. This is a particular area of focus, and one that both of our medical directors are very, very keen to support, and they are championing it from the rooftops. There, you know, they feel it's highly innovative and will give us this centre of academic excellence that will make both organisations somewhere that people want to come. So I'm going to ask for the next slide and hand back over to Kate if I can.
Thanks, Fiona. So we're running short on time, but I did just want to pull out two areas where we're demonstrating value. This is really key for us to keep momentum and keep an eye on how well both the governance is operating, but also how well the individual work streams are developing and delivering. So just very quickly then in the two areas. So the first one around governance is just doing an annual review of the Memorandum of Understanding and an annual review of the effectiveness of the joint working group. So just making sure that the governance is still working and it's still appropriate and it's delivering what we want it to. And then there's the effectiveness of the actual programmes. So each programme has an ambition and some goals, and obviously it has some measurable outputs that we keep oversight of. So the joint working group provides assurance reports to both of our boards, and that's delivered through a highlight report with an assurance rating for each of the programmes. So that goes through to our boards in the same month. We're just conscious that these go to our public trust board meetings, so we have made sure that we've explained the role of the group model to our public, so that any observers can understand the journey that we've been on and what we're trying to achieve. And we actually only went public with it from January this year. But these programmes of work also provide some internal assurance for us, and in some cases we can use these as mitigations on our some of our risks on our board assurance frameworks. So there is a key element in providing assurance, not just to our boards, but also to the rest of our organisations. And with that, I'm going to just hand over to Fiona to briefly describe where we're going next with the journey. So next slide and over to Fiona, please.
Yes, thank you, Kate. So really, key priorities for the next steps are to make what we're doing part of business as usual, part of the warp and weft of what we do, and really start to build on that and get more strength, stretch and depth to our group model programme. As I mentioned before, we're currently planning a board to board to start to reflect on the year that we've just had, and also identify priorities for future for the next year of working. And I can say now that we will be looking at developing more joint roles and more shared roles. We will be looking at a joint chair. There is a lot of progress that we're seeking to make with our group model and really take it to the next stage. But I'll hand back over to Cathy. We're both Kate and I are very happy to answer questions at the end of the sessions. But back over to Cathy for Neil's presentation. Thank you.
Many thanks, Fiona and Kate, for what was really an interesting and informative presentation. I could have heard more, and we can really see that the work you're doing is sort of putting you in good stead to reflect your local ICS priorities. As Fiona mentioned, there will be an opportunity for questions afterwards, so please start thinking about what you'd like to ask our presenters. The second case study this afternoon is going to be presented by Neil Goulbourne, who's the Director of Strategy, Planning and Performance and Chief of Staff at Croydon Health Services Trust. His presentation is on trailblazing integration in Croydon. But before Neil presents, we will first see a short animation.
The One Croydon Alliance, launched in 2017, is formed of 6 organisations, including local NHS trusts, Croydon Council and Age UK Croydon. Together they are working to overcome long-standing inequalities and deliver quality improvement programmes in the face of staff shortages and financial constraints. To achieve this, their approach of local integration with wider collaboration is designed to break down organisational barriers between professions, to give people more coordinated care, support staff, and create opportunities. The Alliance aims to improve the health and care of the local population by bringing together physical and mental health services, social care, and increase the role of the voluntary sector. They are delivering real benefits for the local community and workforce through an aligned vision, plan of action, and joint leadership team. Croydon was one of the first to bring together the local NHS Trust and CCG under a single place-based leader, speeding up decision-making and reducing duplication to invest in quality improvement. They have established community hubs, helping people to stay well by connecting them with the support of services around them, including social groups, healthy eating classes, and support to manage long-term conditions like diabetes. They are also building community by supporting local business through apprenticeships and Kickstarter schemes, and work with local universities to train the next generation of health and care workers in Croydon.
Well, hello everybody. I'm really delighted to be here and to talk to you about the work we're doing in Croydon for the next few minutes. So Croydon Health Services, we're an acute and community integrated trust and have been for the last 10 years or so. We're part of the South West London integrated care system and part of the acute provider collaborative in South West London, which we think is really successful and doing a lot of good work. But that's not what I'm going to be talking about today. Today I'm going to talk about the work we're doing in place in the borough of Croydon to join up services. Next slide, please. So Croydon, first of all, we're a borough in South London. We've got a population of about 400,000 people, so large enough to be a city, I guess, in our own right. A high degree of health inequalities and a high degree of deprivation as well. So a population that's much more similar, I guess, to an inner London or inner city borough. And we've had a history over the years of challenges with quality, with the money as well, I'm afraid. And they've tended to kind of move between the trust, the CCG and the local authority. At any one time, one of us has had challenges in those areas. Next slide, please. And so a number of years ago, what we started to realise was to solve those problems, we really needed to do it together. And so that drove us, I guess, because of the burning platform, towards ever closer working, integration to solve our problems. I think we've been lucky to have coterminous footprints. So the trust, the CCG and the local authority all cover Croydon Borough, and that has certainly helped us to go down this journey. So I want to talk about 2 ways in which we have joined up, in which we've integrated the governance and everything else. So the first one is through our One Croydon Alliance, which is our place partnership. We've got 6 partners, as we said in the video. We've got the local authority, voluntary sector and the NHS. And that's really about delivering our health and care plan. And our plan has been all about reducing the reliance on acute reactive care, moving upstream to much more kind of social community-based model. The other partnership is between the trust and the CCG. And there we've had joint teams, so things like safeguarding has been a single team, a single leadership team across both with a single place-based leader who is the chief executive of the trust as well. And that's been for the last 3 or 4 years. We've got a joint control total, so that aligns our interests, if you like, from a financial point of view. And we've also got aligned governance and an MOU between the trust and the CCG in Croydon. Next slide, please. So I'll say more now then about the governance underpinnings of those two different partnerships that the Trust's involved in. So on the alliance, first of all, so we've got an alliance agreement between the partners, which documents in a good amount of detail the behaviours, the roles, responsibilities and so on by which we work. There is a board that oversees it that doesn't have any delegated powers. It does have an independent chair, and all of our decisions are taken on a basis of unanimity, which on the face of it you might think is very cumbersome. Actually, what that forces is a lot of consensus building outside of those kind of formal governance forums. Underneath that board, we've then got a set of management groups covering things like finance, population health management, and so on. We have SROs in the usual way, clinical leads and so on for our different programmes. So that's the alliance governance. On the Trust and CCG partnership, we've used committees in common to make that work. So our board and the governing body of the CCG have met in common. The same for our principal committees, so quality, finance and people. We share the chairing between them, and we've got a single governance team that lives with me that runs all of that. Now, it's worked really well for finance. We've got a single finance team, a single finance director, and of course money comes in just one currency, or at least in one country it does. So it's kind of easy to compare between different organisations. It's been much harder with quality because although we do have a joint chief nurse who is responsible for quality across both of the organisations, because you've got just so many different metrics, which are really different between, say, primary care, mental health, the acute, it's really quite hard to compare one thing with the next. There's also quite a big difference between our responsibilities as a provider and our responsibilities as a commissioner. And we don't want to confuse those, and it's been really important not to do that. So we've been on a learning journey with it. We're not at the end of that by any stretch, and I'd have to say it's been a lot harder to get the quality governance right. Final thing I'll say on this is what we're now doing is bringing these two partnerships together into what sounds like an incredibly complicated arrangement, but which is actually, I think, simpler and is going to help us with that integration. So we've had the first now of our joint boards, which combines the Trust, the One Croydon Alliance, and also the Place Committee of our integrated care system in South West London. So it's all now in one governance, all through committees in common, and we feel that's already started to work well. Next slide, please. So what have we been able to do through all of that governance and working arrangements? I'll just pick out a few things. Firstly, our integrated locality model of care, where we have joint teams in each of our 6 localities made up of social services, the voluntary sector and health, working in a kind of integrated fashion despite coming from different organisations. We think that's already started to have an impact on emergency demand, although it is incredibly challenging as it is everywhere. The second thing is helping to manage financial challenges. Our council in Croydon had to issue a Section 114 last year, I think it was, so really serious financial challenge. We've been able to find a way through that, through the inevitable cuts that they've had to make, because we have these forums for discussing what we're going to do and how we're going to do it. And I think we'd all agree that that's really helped us to get through it. Working as anchor institutions, the Trust is the biggest employer in Croydon, the local authority is the second biggest, and we've worked together on things like apprenticeships, Kickstart and so on, so that we have a wider impact. And the final thing I'd say is the voluntary sector, one of the key partners in our alliance, but as statutory organisations, the local authority and us in health have been able to be much more joined up in supporting the voluntary sector, and we are now part of a programme with the National Lottery and the King's Fund because of the work we're doing, and I'd happily talk more about that in the future. So what that's all, I guess what unites all of those different things is that we're able to work across organisational boundaries as if we all belong to one organisation. And that's really what the governance enables. Next slide, please. So, I mean, I've shared a couple of lessons as I've gone, but just to finish up, all the usual points about partnership apply here. You know, it takes trust. You have to invest the time in it. You've got to show extreme integrity, I think, and honesty all the time to make it work. It's easy to get carried away with the governance charts. What's really important is, what are we trying to deliver for local people and patients? Start with that and then think what governance is needed to enable that, rather than the other way around. Inevitably, whatever you start with won't work, or certainly won't work optimally, is our experience. So it's best to be honest about that from the start and tell people it's likely to change, give us your feedback, and we'll amend it as we go. It starts to get quite uncomfortable pushing some of these boundaries because it feels like we're moving away from the kind of clear statutory responsibilities of organisations. But I think you have to get into that zone in order to enable partnership working. That having been said, you know, Fiona and Kate mentioned well-led, totally agree with that. You always have to make sure that however far you push the boundaries, you do still have really clear governance that enables good leadership and to be an effective organisation. Involving the people who use the governance, who need to deliver stuff, absolutely critical. You don't want to make it so complicated people can't manoeuvre around it. And in the end, as I said, relationships are what this is all built on. So when it gets difficult, as it does sometimes, of course, going back to those and just, you know, getting together with people and saying, how do we resolve this? That's the best way to do it. So I will stop there. I'm happy to take questions, Cathy.
Thank you very much, Neil. Another inspiring presentation with lots of nuggets that we can take away with us. Particularly interested about hearing how the work of your alliance has been driving some, you know, the benefits for your residents in Croydon, and I'm particularly interested around the place-based approach that you're taking, which I think quite a few trusts and systems are actually still trying to work that one through, and particularly around how you've already got your involvement with your local authorities, other providers and the voluntary sector, which are key in in helping us address these health inequalities. I think there's a wealth of learning and experience here, but before I go on to sort of addressing or asking any questions, I just wondered if panel members had any further comments or observations, having heard each other's presentations. Fiona, Kate or Neil? If not, we'll move on.
I was just going to say, Cathy, I think it's really encouraging to hear quite how much collaboration, involvement, how much we are trying to erode organisational boundaries, still respecting those boundaries where they need to remain, where we need to remain as sovereign organisations, but really trying to just push that envelope a little bit. So I'm really encouraged by what I've heard today about the work that Neil and his team and his colleagues are doing. And I think it's great to hear it. It's complex, it's difficult, there will be more of it, but we just need to embrace it, really.
Yeah, I was going to say something similar, actually. And, you know, that kind of principle of collaboration, you know, in very different circumstances, I guess, between the two of us, you know, different projects, but recognizing that we'll do better working together than working separately is what sits behind all of this. And I think what's so exciting to hear is that people aren't saying, you know, neither of us is saying, you know, either you have strong governance or you have collaboration. We're saying you have to have both, you have to make it clear, but don't get kind of lost in the governance. It's a means to an end. So yeah, you know, really strong parallels there, which I'm sure, you know, will be shared by others too.
Yes, and totally acknowledge that and recognise that. We have some questions coming in, and just to remind you, please do post your questions. Even if Fiona, Kate and Neil are unable to answer them today on this session, we will be able to get back to you with some answers. So the first question I have is from Adewale Kadiri, who's asked, is the final destination of the group work between Northampton and Leicestershire a full merger, especially with a trust and an FT being involved? Otherwise, there's potentially a danger of duplication with two boards, etc. And on a more practical level, will annual reporting be done on a group or an individual trust basis? So there's two questions in one there.
Should I start with that, Cathy, and then Kate can come in with any views that she wants to add. So no, it's very much a group model based around improvement, how we can build both organisations, make both organisations stronger, enhance both organisations by looking at these opportunities where we can learn together and then share that best practice within our organisations. It does make reporting quite complex. In fact, as I'm sure many colleagues on this in today's seminar will be also battling with finalising their annual report and accounts. It does make it quite complex to actually describe what we're doing, and what we're seeking to do with between ourselves is have a boilerplate that describes what we're doing in both organisations, that we put in both annual report and accounts, and just make sure that we're making the commensurate links through to things like the remuneration report, where we have got joint or shared roles, to make sure it's absolutely transparent for the public. So no plans for full merger, very much based around joint working and making improvements. And essentially we're operating in the committees in common structure, so we're just bringing those committees in common together on a regular basis to actually just check in that the work that both boards have identified for each trust working together are actually being completed. I'm going to just stop there. I don't know if Kate's got anything else to add.
Thanks, Fiona. Yeah, just to build on what Fiona's just said, actually, we are in different geographical areas, and so we are wedded to our own ICS and system development work, and it's our communities that we work for that are really important to us. And so the shared priorities that we have are to enhance our performance in those areas. And whilst that's really important, that's not something that we would be looking to merge or come together on. So it is there to enhance what we do individually. Thanks.
Thank you, Fiona and Kate. There was the second part to that question, which was around what are your intentions regarding joint annual reporting? Are you going to do this on an individual or a joint basis?
Yeah, so we will retain individual annual reporting, but as Fiona mentioned, we will have the group model and the importance of that within both. Fiona, I don't know if you want to add to that.
I think that we're just in the process of planning a board to board at the moment. So this will really help us determine exactly what we want to do next and how much closer we want to get. We will still very much remain two sovereign organisations, but I can't say that we won't produce one annual report and accounts for the group model, but the plan for the moment is that we remain two sovereign organisations joined by this improvement programme.
Thank you, Fiona and Kate. Oh, sorry, we have another question. This time it's for Neil, and it's from Marnie Haywood. Neil has highlighted there are challenges with a joint chief nurse having both provider and commissioner responsibilities in relation to quality. Can you expand upon the challenges, and does it create any conflicts? Neil.
Yeah, thank you for raising that. So I think there's just a practical challenge. Firstly, I'm speaking on behalf of my colleague, but I think she would say that particularly during COVID over the last 2 years, there's been so much to focus on as the chief nurse of a provider, an acute and community provider, that there's just a kind of practical challenge with being able to oversee both of them, even if you've got the right people in post and so on. I guess the kind of pace and intensity of the day-to-day in a trust is really hard to get away from. Now, I think to some degree we all find that whichever role we do, that there's a kind of drive to return to accident and emergency, for example, because there's so much pressure there. So that's one practical challenge. I think the other thing was what I referred to, which is that our CQC regulation, for example, for the trust requires certain things of us. And we have to be very clear in things like the quality committee, that we're discharging all of those responsibilities. What we tended to find to start with when we brought the quality committees together was that the agendas were starting to get a bit kind of muddied, I suppose. It wasn't completely clear sometimes whether an item was there as a trust item or a CCG item, and were we in kind of internal governance mode, or were we talking about a different provider, and should that other provider actually be there in the meeting, for example? When we had our non-executive directors commenting on a different provider in a discussion about commissioning, it was a useful and interesting discussion, but it did start to feel a bit peculiar at times, because they're not in a position really to hold another provider to account. So we've disaggregated some of that, but had it within the same meetings so that it's clearer what roles people are performing at any given time. And that's really helped. But as I say, we've got further to go, because it doesn't feel to me like we are really seeing the whole patient journey across different providers, and that's really the purpose of doing it in one meeting. And I think that's not easy, but we've got to get there.
Thank you, Neil. We actually had another question, which I think you have addressed in your response just now, which was from Adewale Kadiri, which was also looking at how do we effectively and transparently manage potential conflicts of interest within the joint commissioning and provider model. And I hope, Adewale, that you think that Neil has answered those questions, or your question.
I can say just one more thing on that, if that's helpful.
Please.
Yeah, I mean, we've been acutely aware of the conflicts of interest, of course, and so we do all the standard things of declarations and so on. But I guess our perspective has been very often the conflicts are useful, if you like. It's because people have an interest. The GPs have an interest in what's going on in the hospital and vice versa. It is very much those interests we're trying to bring to the fore. And where it comes to a commissioning decision, of course, we take that separately. So anything that's commercially sensitive is handled as you'd expect. But I think, we've been clear that we should be open about conflicts, but not try to completely avoid them, because in a sense, that's kind of the purpose of bringing everybody together.
Yeah, I totally agree, Neil. Totally agree. If I may, I have a question actually, and this one is for Kate and for Fiona, and it's really partly because of my personal interest at the moment. At ELF, we're currently recruiting to a joint chair with our neighbour trust, North East London Foundation Trust. It's been an interesting and positive journey with sort of collaborative working amongst our governors, as our boards as well. And we've certainly got some nuggets of what we've learned on the process. We've not completed it. We're still on that journey. And I think for us, the most important things was around communication and really strong allowing the voice of the governors to be heard. I think what's interesting with both ELFT and NELFT is that we've taken the view of looking at a joint chair role first, whereas within for Fiona and Kate, you've looked at executive level, so it's much more of an operational approach. And I just wondered what your intentions are regarding, or why you started that way, and then regarding any NED joint posts going forward. And you've got about 30 seconds to answer.
I'll say that first. So this is a very complex area, and so for all people tuned in, so FT to FT group model, quite straightforward. FT to trust, less straightforward, because in actual fact the process is managed through NHSEI because of the different legislation that's in place. Trust to trust is obviously managed by NHSEI. So part of the reason why we have done it in the way that we have is because of essentially because we're a foundation trust in a trust, and it was just easier to start that way, really. I could speak more about this, but I'm just conscious of the time. But it is something that we're carefully picking our way through. We will certainly have our governors fully involved in this, but we will be following a process that will be largely led by NHSEI, because it's for them, it's a public appointment process rather than an FT appointment process by the governors.
Thank you, Fiona. I'm mindful of the time. We really are running over, so apologies. I shouldn't have asked my last question, but that was Chair's privilege. I just want to say that over the last 2 days, we've heard the importance of having a shared vision, that the working in partnership and collaboration requires both processes, infrastructure, governance, but there's also something around the relationship building and trust and development of cultures in common is absolutely key. So the opportunity to have joint roles, joint committees, joint working will really help with what I want to coin a phrase is about we are stronger working together. I'd like to thank everybody for your questions, to NHS Providers for another excellent and topical conference, and particularly to Fiona, Kate and Neil for your useful and enlightening presentations. And I really hope, like me, you've got some of your own takeaways to share within your trust and within your systems. So thank you, everybody. I hope